come on the 46th. So officially we complete 4 years. 22nd of May was the first, 22nd of May 2022 was the first one. So thank you to all of you.
Thank you, ma'am, for giving me this opportunity to interact with the wonderful people that have been working along with you. And it's a privilege to be a part of today's webinar. So before going into it, I would like to introduce the first speaker, and she's going to talk on functional outcome measures in SMA. So I'll share a brief CV of her. I hope it's visible. So the first speaker today, she's going to talk on functional outcome measures in SMA is Ms. Gauri Khandekar. So she's a senior pediatric physiotherapist, early intervention and neuromuscular rehabilitation specialist with 22 years of experience in pediatric physiotherapy. So ma'am, over to you, and please start the session.
Okay, good evening, everybody. Thank you, Dr. Smelu, for that introduction. Thank you, ORDI. Thank you, Dr. Anne, for giving me this opportunity to present this talk today. So I will just share my screen. Should we start, ma'am, or should we just wait for another 5 minutes? We have around
65 participants.
65 participants. Should we go ahead? Dr. Anne? Okay, I think we'll start. Is my screen visible?
Yes, it's visible. You can put it in the presentation mode.
Okay.
Yeah, perfect.
Right. Okay, so my talk is about a standard functional assessment in spinal muscular atrophy. So everybody knows about the spinal muscular atrophy. It is a problem with the, just a minute, I have to just reduce the screen. Okay, so spinal muscular atrophy is a defect in the SMN1 gene. So SMA protein is not formed. So the functional classification in spinal muscular atrophy is SMA type 1, type 2, and type 3 and 4. So according to the classification, the severity goes from SMA 1 is the most severe types, and then 2 and 3, 4 are compared to that less severe. So how the SMA type 1 will present is they will have a lot of weakness in the trunk, in the upper limbs and lower limb. The mother will observe that the kicking movements are reduced, the reaching is reduced. You can see a lot of tongue fasciculations. So this goes with the SMA type 1, and the usual life expectancy is very low. The child has a lot of problems in respiratory and swallowing muscles also. Type 2 is seaters, where the child is able to sit but may not be able to walk. So you will see a lot of twitching in the arms and thighs. The child may have a little bit of, he may have the head control, but usually what you see is when they go into complete flexion, it is very difficult for them to get the head into extension. So that is a sign what we usually see, because otherwise if you just maintain it in the middle position, the child can hold for a little time and they can turn also a little bit. But when it goes to complete flexion, it is very difficult for the child to get into extension, and the same happens in prone position also. And type 3 and 4, they can be walkers, but depending on the condition and depending on the progression of the disease, they might lose the ability to walk. So they are at a very high risk of osteoporosis. So fractures and falls are very common. And usually the weakness is more seen in the legs, and eventually the child will stop walking, or if they are walking also, there will be having a lot of contractures, deformities, and spinal curvature issues also. So in SMA manifestations, the most severe type will be 1A. So the type 1 is again divided into 1A, 1B, 1C. The type 2 is into 2A and 2B. Type 3 is 3A and 3B, and type 4. So this is mainly for the neuromuscular specialist, the neurologist, to see what are the type. So as a rehab professional, we will have to look into the type of muscle weakness. How is it? And then we can progress for the assessments and the intervention strategies. Okay, so what is the basic need of the assessment? So it helps us understand the natural history of the condition and course of the symptoms. It helps us understand the efficacy of the intervention and helps in monitoring the functional status of the child. So functional outcome assessments, which are standardized in SMA, are for the non-sitters, Heine, CHOP Intent, HFMSE, and Attend. We will be going through all one by one. In sitters, Heine, CHOP Intent, HFMSE, RULM, and MFM. And in ambulant, it is CHOP Intent, HFMSE, RULM, MFM, and time tests. Because the child is walking, we can do some time tests also for them. So the first is Heine 2, that is Hammersmith Infant Neurological Examination. It has 3 sections, but what we use for SMA type 1 and type 2 children are the section 2 of Heine, Heine 2. So it has 8 items and has a maximum score of 26. So we see what the child is able to do. It goes from the hand grip, it goes then the kicking movement, then the milestones what the child is showing. So the total score is 26. So we have to see and mark out of 26. So that is Heine 2. The second one is CHOP Intent, that is Children's Hospital of Philadelphia Infant Test of Neuromuscular Disorders. So it is widely used. Basically, it is giving us a natural history studies actually, and so like if the child is on nusinersen, risdiplam gene therapy, this is a very sensitive test for SMA. So and it is designed for the weaker infants also. So it really captures the deterioration. So there are 16 items and each is scoring from 0 to 4. 0 is completely no response and 4 is the maximum response. So obviously, if the score is high, the motor function is better. So, and best side per item is also counted. Like if the child is able to do better with the right hand, right leg. So you can mention that the right side is better than the left side. And MCID was seen to be around 3.4 to 4 points. Now we come to the third test, which is Hammersmith Functional Motor Scale, HFMSC expanded. So what we see here is the gross motor function. It is mainly seen in type 2 and type 3 because the item starts with the children in sitting. So if the child doesn't have sitting also, the HFMSC we don't use. We go to the CHOP Intent and Heine more. And but it is again a very sensitive test, widely used in clinical trials with all the DMTs. DMT is disease modifying therapy, and in the natural history studies also. So it will give it will detect the changes over the time and treatment responses. So it helps the guide. It definitely helps the physiotherapist for setting the goals and assess the disease progression, because the items what we see in HFMSC are our normal gross motor development. So whether the child is going on arms, then like weight bearing on the arm, weight bearing on the elbows, weight bearing on the arms, and how they are turning. All these things are then up to the crawling, standing, walking, everything which will follow the gross motor pattern. So that will give us the goals for the therapy also. And there is one expanded this thing. This is the same one. Sorry, it has totally 33 items, 3 3-point scale, which has maximum score of 66. So basically in the expanded form, the items goes from half kneeling maintenance, then jumping, then going up and down the stairs with support, without support. So all this is in expanded. So if the child is standing and walking, we can get basically for SMA type 3 and 4, we can get this also recorded. So the consistency maintained across the international clinical trial settings, MCID often considered 1 or 2 points even in the clinical trials are considered as meaningful. So revised HFMSE is the expanded version, was developed by Matthew Maison and colleagues in 2020. So here we are just eliminating the flooring effect from very weak or very strong individuals with SMA. It has 36 items, again 3-point scale, maximum score of 69, and increase scoring consistency across the evaluators compared to the original HFMSE due to the clearer definitions. So here we are again having some more items to check, which will give us the assessment in a better way. So this is a maximum score of 69. So what we had in HFMSE was 66. This is the upper limb test, which is called RULM, revised upper limb measure. It is again very sensitive for SMA and widely used in the clinical trials. So specifically, it is measuring the upper limb functions, and it is very sensitive to the small changes in arm and hand function. Again, it has the items from the shoulder to elbow to fingers. It includes the proximal to distal movements. There are items which are seen in all these according to the joint, and it is a very sensitive test. So it has 19 items, 0 to 2 and 0, 1, 2. So total score is 35. MDC is 2 points, and MCID yet to establish. So these are the time tests. Many of you will be aware. So this we talked about in DMD talk also. So this is 6-minute walk test, 10-meter walk test, and TT rise, that is rising from the floor. So 6-minute again is a functional endurance test. We have to we have to calculate the distance in meters. The child is is asked to walk maximum in a safe environment at a safe speed for 6 minutes, and then we see the time taken for we see the distance covered in 6 minutes. And in time meter walk test, it is indicator of the ambulatory function. Here we ask the subject to walk at the maximum speed, how much they can do up to the 10 meters, and we see the time in this particular test. And if the child is able, if the individual is able to rise from the floor, again we see the time taken to be which tell the individual or tell the subject to lie down on the floor, completely on the floor and not even on the mat, and we tell them to stand up as quickly as possible, and we see the time taken for this particular task. So based on the functional status, these are the tests which we use for non-seater, high knee, chop intent, and ascend. We will be seeing it is a caregiver questionnaire. Ascend, we will come to it. So others are respiratory check, swallow function check, because non-seater means essentially SMA type 1. So we will have to see for the respiratory, swallowing, and orthotic check, and scoliosis check. Based on the functional status for the seaters, we will have to do chop intent and HFMSE, as I explained, because HFMSE starts with sitting. So we can do HFMSE, we can go to RULM also. And these two tests are again caregiver, SMAIS, and ascent that we will see. Apart from this, again, the respiratory, swallowing, and orthotic check and scoliosis check is mandatory. Then for the ambulant, it is revised HFMSE, then RULM. MFM is a motor function measure that we have not included here because it is, but it is a good test. It's not exactly validated for SMA, but it is giving us a lot of idea about the function that varies from the upper limb function to the trunk to the lower limb. So we use in our setup, we use MFM also. And we definitely, with ambulant children, we have to do the time tests and SMAIS and ASN. Here we have to check about the fatigue, the orthotic check, and the TCD, means that this is a tightness contracture deformity for the ambulant children. So these are the two caregiver reported measure. SMAI is a spinal muscular atrophy independence scale. It is a patient, if the patient is able to answer, you can ask them or the caregiver. The domains which is covered is self-care, mobility, and communication. It is validated from SMA, from like across time, type 2 and 3, with a strong reliability and sensitivity. It can be used for 12 years and older. And ASCEND is a caregiver questionnaire again for the assessment of caregiver experience with the neuromuscular disease. So how is the impact of that and burden of caregiving, basically. So it is giving us the idea like physical demands, emotional stress, social impact, time investment. So it is actually giving insight into the family and basically the caregiver perspective, which is essential for the holistic care, because we have to take care of the caregiver also. So this is a summary score sheet what we use in our center. And as you can see, we are we have mentioned everything about the outcome measures. At the same time, we are understanding what the child's present concerns are, then the disease modifying therapy if he has taken any. Then functional motor status, depending on that, we will have to think about the outcome measures. Then the respiratory support, tracheostomy or suctioning or any BiPAP is machine given. So how many hours the child is using. Then if they're using any suctioning or cough assist, then is there any history of fracture? Then is any history of casting, surgical history? All this is very, very important for planning the goal. And we definitely look into the tightness, contracture, deformity, and assistive devices. And as I mentioned, these are the functional outcome measures. We always see the previous one also. Like if the child, the subject has come after 3 months, then the previous one is noted and then the current is noted, so that you can immediately compare the scores and see whether the child is maintaining or the child is deteriorated or the child is improving also if in case of DMDs. So this is just an example. One child was SMA2. He was awaiting for gene therapy. We did the FOMs, and we saw that he's deteriorating in the functional status. So immediately the decision was taken by the neuromuscular expert to start on the RISD plan. So the functional status was maintained. So in the current practices in according to the 2018 consensus, we have to do the periodic functional assessment. Type 1 is 2 to 4 years, 2 to 4 times in a year. Type 3 is twice a year. Type 4 once a year. And definitely it varies with the severity and accessibility and also DMT, because in disease modifying therapy, definitely we want the child to come regularly to see the effect of the medicine. So after DMT, according to the neuromuscular expert, the protocol is followed and the functional outcome measures are noted. So these are the few research papers. I mean, this is a European Journal of Pediatric Neurology, where our team, I mean, with Dr. Anne, there was standardized functional assessment translating into generic form. This paper was presented. These are the functional outcome major improvements. These are few papers what we had presented, our team had presented in AOC in 2023. WMS 2024 also we had presented about the functional progression in post-nusinersen therapy, and the latest was WMS 2025, where we had again presented 3-year follow-up post-nusinersen in the spinal muscular atrophy using all the functional outcome measures. So what are the triumphs of that? It provides an excellent and a real feedback about the functional status of the individual. It has it plays a pivotal role for the neuromuscular expert to take the management decisions. Then it is a strong indicator of existing or developing the complications like spinal curvature, respiratory deterioration, then it is definitely giving us the feedback about intervention. And it creates a drive or motivation in the individuals and the caregivers. If the child is on, especially when the child is on DMT, all the scores, improvement in the scores definitely is a motivation for the parents and the caregivers. So what are the challenges? These are the few challenges. What we have mentioned is our neuromuscular centers accessibility is less. Then there's a lack of awareness about the importance, like how important it is, people don't know. So the lack of training also, because all the assessment schools are valid, they're standardized. So we have to undergo training how to use it. So we make minimal mistakes. And then fatigue and respiratory, sometimes the fatigue and respiratory problems are there. So we cannot assess the child completely. And obviously the travel and expenditure for the repeated assessments. But apart from that, if the individual is coming for the regular functional testing, it gives a lot of idea about the functional status, and in turn, it will help us for the interventions. So, thank you.
Thank you, ma'am, for that wonderful talk on the functional outcome measures. So participants, if you have any queries, you can post it on the chat box. We'll address it at the end of the talk. So next we have the talk on physiotherapy management in SMA by Ms. Neha. Yeah.
I hope my screen is visible. I would like to start off immediately without wasting a lot of time, wasting any time. So thank you for this opportunity, ORDI, and Dr. Smilu for moderating this session, and Dr. Ann for this opportunity. So first and foremost, we'd like to say that today we are briefly discussing the principles of physiotherapy management in spinal muscular atrophy, particularly because like traditionally, rehabilitation in SMA focused mainly on prevention, like preservation and prevention of secondary complications. But with the advent of disease-modifying therapies, things have changed. The focus has shifted majorly on optimizing the function. So let's see, before we get into that, first let's try and understand how an SMA muscle is different from how a spinal muscle atrophy muscle is different from a normal muscle. So if you see the picture itself, there's a lot of difference. So muscle belly, the number of muscle fibers, there is a good chance of fatty infiltration, loss of motor unit. Sorry about the AN here, AN SMA, so SMA muscle, right? So it generates lower force than force for the same neural drive. So it has impaired mitochondrial function, so it is more susceptible for fatigue. So these are the things that we have to consider while excess prescription. So that's why we are discussing how different is this muscle from a normal muscle. So the recovery period also is pretty slow. So higher energy consumption to, say, perform regular activities, and the amount of compensatory movements also is pretty high. So we have two separate, eras now, the eras or phases in the clinical course of a child or a person with SMA. First is the pre-disease modifying therapy, DMT, that is pre-disease modifying therapy phase, and post-disease modifying therapy phase. So we're going to be looking at goals separated into those two phases because there is a lot of difference. So now we learned how SMA muscle behaves. So based on that, let's try and understand what are the goals that you set, physiotherapy goals for a non-sitter, sitter, and an ambulant SMA person with SMA. So for a non-sitter, potentially they are SMA type 1 and type 2, our function is majorly preservation of function and prevention of complications. So keeping that in mind, prevention of contractures, optimizing positioning, promoting respiratory efficiency, maintaining the participation and interaction, and facilitating head and trunk control within tolerance. So this is a key word here, so which will probably keep repeating. So in order to meet these goals, what are the kind of interventions that we are going to opt for? First and foremost, we're going to look at gentle active assisted movements. If required, only we're going to go in for a passive therapy. So gentle active assisted movement, absolutely necessary. Daily stretching routine. So that is to prevent contractures. Position changes. This is for both contraction prevention, integumentary changes to prevent any pressure-related wounds, or even for respiratory therapy for that matter, which we're going to learn more a little bit more in detail. For non-sitter respiratory therapy, hydrotherapy, if and only if tolerated, because as we know, gravity plays a major role in prevention of gaining neck control, especially in type 1 and type 2. So hydrotherapy, yes, it might be beneficial only if tolerated, and everything has to be play based, because we are trying to reintroduce the maintain the participation and interaction of the child. SMA children are intellectually very good, so we need to keep the cognitive elements, cognitive faculties all active. So play and active interaction, participation, learning, absolutely necessary. So those are our goals for non-sitters. So this is again pre-DMT we are talking about, pre-disease modifying therapy. For sitters, what we want to do is we want to again preserve the sitting balance. So if they have achieved sitting, we want to preserve the sitting balance, and how much of function is possible in sitting, we're going to opt for that. So again, we're going to focus on delaying contractures, and scoliosis is a very high risk. So once the child learns to sit, the child and the parents most of the time they prefer being in sitting position. So it has an impact on spine because the weakness is not going anywhere. So it is there, and in fact pre-DMT it is still progressing. So scoliosis is a risk. So delaying contractures along with scoliosis, keeping scoliosis in mind, is absolutely necessary. Maintaining upper limb function, so that's more functional ADL, they can participate more in their ADLs. Improving the endurance. So how are we going to achieve that? Moderate strengthening exercises. So moderate is the key word here. So we're going to not fatigue the child at any cost. So we can move on to say supported standing with a standing frame and necessary assistive devices. Trunk control exercises. So this is going to help activate their their proximal trunk muscles, and then explore a little bit of their dynamic stability. So, and low intensity aerobic exercises and aquatic therapy can be well tolerated in sitters, right? And coming to ambulance, again, we want to maintain the function. So the neuromuscular expert will straight away send them to a dietitian as well, because their BMI has to be maintained. As and when they gain weight, the chance of losing their ambulation is still there. So that is one. Improving their endurance and delaying the deconditioning. So for that, again, here the key word is submaximal strengthening. Low to moderate aerobic exercise training, swimming and cycling is definitely encouraged, and balance training. So again, the key factor here is a gentle active assisted exercise, moderate strengthening, submaximal strengthening. So we are never putting the patient or the child in the fatigue levels. So we are making sure we stop the exercises before exhaustion, right? So that is a key word here. So that is all pre-DMT era, pre-DMT phase of the patient. Now moving to the disease modifying therapy, we have Zolgensma, that is gene therapy, oral risdiplam, and then nusinersen. So I'm not going to get into the details of this, but currently with the advent of these three drugs, things have definitely changed on the therapy wise as well. That's why so what changes in the muscle after DMT? So after DMT, the survival, the motor neuron survival, improved motor neuron survival happens. So the amount of denervation, it's preserved. The whole degeneration process is arrested. So there's no further deterioration. So improved motor unit recruitment. The fatigue that used to happen now is delayed, right? It's not going away, but it's delayed. There's better strength and endurance. You can see that the milestones the children start to achieve, reduced rate of motor decline, and improved exercise tolerance overall. So post DMT, what we're trying to do is we're going to try and take it up a notch, right? Again, so keeping all the precautions in mind, for non-sitters, we're going to promote functional transitions, neck control and trunk control exercises, get them to do more play-based activities, adapt mobility training and things like that. So before, like SMA type 1 would not sit. That's how they would say it. Now we have post DMT SMA children in our setup actually doing supported standing. So that's why prevention of contractures and complications during the pre-DMT phase becomes absolutely necessary, because post-DMT, these children actually have the potential to even take a few steps going ahead. The non-sitters and sitters, SMA type 2, essentially, many of our children are actually ambulating. So yes, the more important, the more carefully you tread in the pre-DMT phase, post-DMT phase, you can definitely take it up a notch. Gradual, yeah. Gradual is the key word here, because again, as I said, fatigue doesn't go away. It's just delayed. So the child probably has a little more strength and endurance to do a little more than before. But that doesn't mean that we start overloading the muscle, right? Functional reaching, transitions, supported standing. Again, orthotic support is absolutely necessary for both non-sitters and sitters. Ambulant, a little more aggressive is there. Approach is taken where you are looking at dynamic balance and gait training, progressive aerobic conditioning. So again, what are the precautions here? So fatigue is something for both pre-DMT and post-DMT. We cannot let it go. Rate of perceived exertion is something that you can consider. Ask the parents how the child is doing after an exercise session. Maybe tweak with the intensity of the treatment. Take regular rest periods. So these are certain few ways you can manage the dosage or intensity of the exercises. Respiratory care, we're going to learn more about it later. Avoid premature standing. So many of the times pre-DMT to post-DMT, as I said, the children are improving very well, but we need to be careful and not to be too ambitious in, say, making them stand and making them step and walk. Please look at the trunk alignment thoroughly, assess the assistive devices that are required, and then move forward, because you don't want to put undue stress on the hip and on the spine. Adaptive equipments, timely, it needs to be reviewed and changed. We'll learn more about that next. Supportive care, nutrition, feeding, and hydration, absolutely necessary. So the key precaution here is fatigue and respiratory. And not exhaust the child too much. So again, what is the evidence? So this is a major question that is being asked since 2018 to now, from what I was able to compile. So we have our standard of care consensus. Apart from that, a few Delphi consensus here and there, and small group literature that are available. So stretching, what are the things that are strongly recommended? Stretching, good positioning, absolutely necessary. Respiratory care, supported standing, right? Taking it to the next level. It is allowed, but the intensity has to be low to moderate. That is what the literature says right now. Exercise is generally safe when it is submaximal. Moderate aerobic exercises, contracture prevention remains absolutely essential at all phases. Standing programs for bone and joint health, respiratory physiotherapy remains critical. Rehabilitation goals change substantially after DMTs, as I said, taking it up a notch, but in a gradual and cautious manner. So what are the areas of limited? So these are newer therapies. I've managed to cover a few because these are new therapies that have come in and sort of created a big, it's making a lot of noise positively in pediatric rehabilitation, but is it applicable to spinal muscular atrophy? Let's see. Again, the evidence is always a concern with newer therapies. With CME and DMI, they look at majorly the gravity-driven active responses, and you're looking at postural responses. You want the child to learn by you precipitating certain movements, a lot of trunk activation, dynamic movements, and the child will have some motor confidence. But then again, the evidence is quite limited, all small group anecdotal therapist reported, so it is opinions of therapists only, so it is the lowest level of evidence so far. NISTEM, in my opinion, I think it's very good because even with MMT 0, 1, and 2, Gertie or NISTEM gives a very good opportunity to keep the muscles active. So yes, NISTEM is something personally I would prefer over more dynamic therapies. Of course, aquatic therapy, there's no impact on the joints, so they're able to stretch, move their body very well. So some low level or evidences are available. So aquatic therapy is a definitely promising approach. And other intensive program is something a lot of our parents ask for. Fatigue, again, so whatever things I just spoke about to be careful of, intensive program sort of works in different way. So sure, it requires a neuroplasticity related motor control, motor learning approaches where you're doing a high frequency repetition to trigger more of learning. But then at a peripheral level, is a SMA muscle ready for such load is something that you have to clinically see and then take a call. So finally, take home messages. Rehabilitation is essential pre and post DMTs. Evidence supports moderate exercises. Multidisciplinary is a key. We cannot do things on our own. We need speech therapists. We need orthotic support. We need orthopedic support. Back and forth from clinical neurologist. So whoever, the entire multidisciplinary team, we have to have a discussion always. So the goals have evolved since DMT a little more, again with caution. Individualization is critical. So there is no one size fits all therapy at all. So the kind of improvement that you see even in muscular pattern, if you map with the children that who come to our center, some of them have better quads control, some of them have better pelvic control. Co-contraction is a problem for a few, but they do some of them work very well with closed kinematic exercises. So like that, individualization is very critical. We cannot generalize, is what I feel. Evidence gaps still remain, and please remember it's about empowering the children to improve the participation. It's not about improving MMT from say 2 to 3 or 3 to 4. It's about achieving that functional 3 to 4 points in HFMSE, which makes a lot more difference because it's more functional in nature. So please, we are open to questions. Kindly use the Q&A to ask as much as you like. Thank you.
That was a wonderful talk, Sneha, and you had covered it very beautifully, the pre-DMT and the post-DMT aspects and how to go about it, and also covered the recent aspect on the different modalities, because the usual doubts that we get on aquatic therapy, the CMI, DMI and everything. So it was really a good one, and thank you. We'll take the questions at the end so that it will be more comfortable. So
Sure.
the next I would like to invite Mr. Mohandas, who is a senior pediatric physiotherapist with a special interest in neuro and respiratory rehabilitation. So he would be talking on respiratory management in children with spinal muscular atrophy. Over to you.
Thank you for the introduction, ma'am. Thank you, team. Thank you, the host. Thank you, Dr. Ann, Dr. Smilu, and the other officials involved. Thank you for your valuable time. It's been a wonderful journey along. I hope my screen is visible here.
Yes, your screen is visible. You can go to the presentation mode.
Yeah. So yes. So all these professionals have discussed more about how to go with it in terms of neuromuscular management, in terms of how to target the evidences, what are all the drug-based therapies and all those things. My scope of domain is majorly noted on the respiratory domains. So the objective for the respiratory impairment covered and respiratory therapy in SMA is We will be seeing what are all the basic conventional techniques, breathing control techniques, and instrumental techniques that has already been available and already been practiced clinically, and what are all the physiotherapy for different SMA types and physiotherapy in scoliosis along with the evidences. So first, I would like to say that whenever you get a references, please do identify the lung segment that is involved. That is the first step. Say, for example, in this, after the consultant prescription, I would like to add an example of left lower lung. When you choose the lung segment, the next step is going to be choose the appropriate postural training positioning. So this is the second key. And the third step is it is always about PD and PV, percussion and the vibration. Now the question is whether it is cupped and or the percussion cup. Usually percussion cup will dissipate the forces equally and it will be very focused and specific. Cup done will not be able to give a particular area or the targeted hand, especially in the younger population with SMA types 2 or 3. It will be a little difficult for us to do a percussion. And chest vibrator, the Decathlon massage vibrator is a valuable clinical source. Choose any one of these position, but the common position here is always right side lying and the left side lying that covers most of the lung lobes. So that is the common choice position. And for position related to the infancies, we can use the mother's lap with the help of pillow and then we can teach them how to do the percussion and vibration. So just briefly telling you how to go with the positioning and the vibration. Here I'm using the hand first, followed by the cup. Using a percussion cup, how specifically we are working on it. And the vibration, targeting the right side lying using the vibration. The repetition here is 15 to 20 seconds per lobe, and the percussion is the count of 15 to 10 to 15 per area. And what could be the cost of it? Averagingly, the percussion cup would be cost about 300 to 500. And where it is available, this is the link. And Decathlon, wherever the Decathlon store you go, you get this vibrator, massage vibrator, and it's a good source of material also. So coming to the basic breathing control exercise, when we talk about the breathing control exercise, it is all about expiratory flow bias. A lot of evidences do suggest that whatever you take and do expiratory flow bias is something that is gonna make out the lungs open and make out the cough better way and to improve the functional cough effort also. Out of which ACBT. ACBT is the gold standard technique of expiratory flow bias because it involves a various pressure at the high lung volume, mid lung volume, and the low lung volume. Let us see the brief video about how ACBT happens. So first is always about the breathing control. The second step is about thoracic expansion exercise. And the third is about involving the force control in terms of huffing and coughing. So including force expiratory technique is something that will take out the secretions even more better. Most of the children will not be able to follow all these 5 steps. At least if you could take them and teach them the how to use huff and cough because their expiratory flow is actually very less. So at least some amount of paper blowing and pursed lip breathing, followed by some amount of bubble blowing or whistle blowing, something like that, that involves more of expiratory flow bias, as Sneha Madam discussed about the play therapy. After doing all these things, and if you introduce some kind of a technical exercise like this, that would be really helpful for children. And much of instrumental technique, bottle pep in international countries, there's something called as peripep that is followed. But here, usually in my OPD, I usually suggest bottle pep with the water filled by use of straw, blowing out some 5 to 10 repetitions, waiting for how a child reacts. But the concern here is the child should not be able to suck the water, that we have to educate the child in a better way. Another PEP devices, gold standard is acapella. Acapella has a good amount of vibratory resonance, and where the acapella we will be purchasing, the link is here. So just to show you how acapella works, it's a wonderful breathing control device. When you use acapella, please do add other adjuncts such as huffing and coughing. And the next technique is flutter. Flutter has a good amount of oscillation. You could see the sound. It has a good amount of oscillation resonance to take out the secretions from the lower zones to the upper zones. As mentioned, we got to use the force expiratory technique or huffing or coughing included in the technique. And where do we get this flutter? Flutter is one end it's costly, and other end the other brands are also coming up for a flutter. So these are all the links that we could get the flutter also. And this is the clinical advice. most gold standard practice is aerobica, because aerobica has the mechanism of one valve, which means we can fine tune the resistance according to the child level. As mentioned, 10 to 20 times we got to do, and huffing and coughing technique should be in the adjunct of this aerobica. Aerobica is an excellent uh, device for us to consider, because aerobica has a high amount of vibration as well as oscillatory force. We can get this device in Tata 1mg app or online Apollo Pharmacy, typing with Lupin Arabica device. And what could be the other source of information is high frequency chest wall oscillation West. This is more helpful in CF, but few trials like SMA type 3 and SMA type 4 children who are at 6 years and 7 years will be able to benefit more than in that age group, because it has a good amount of oscillatory and vibratory source. But the problem here is with the size adjustment, we will not be able to exactly find and fit exact size of the child, because the child's growth and the trunk maturity is something different with each and every children. What is the alternative of rest? So this could be the major domain of me stepping into a respiratory physiotherapy in more of an SMA, in more of an neuromuscular diseases. And I'm also a PhD research scholar who's been consistently working on children with neuromuscular diseases. And my major source of therapy topic is about the cough assist therapy. We have done from part of Manipal Hospital's old airport road at the pulmonology team. We have done enough of evidences and resources for the cough assist device therapy. Here is a child who is using the cough assist therapy at home care, which has been guided by me on the online consultation. It is a very friendly device. The device actually sends some amount of insufflation to or inspiratory pressure to open out the lungs, immediately to suck out the secretions by means of expiratory flow bias, to take out the secretions from the lower wall lung zones to the upper lung areas, in thereby maintaining the airway clearance. Cough assist therapy is an excellent modality whereby it is very friendly and feasible, can be adapted in all the clinical situations, starting from the emergency ICUs to the pediatric ICUs, all the intensive care units, ECUs, to the ward as well as the home care protocol also. And what could be the other possibilities of rehabilitation involved in SMA, other triads? I am focusing more on the functional levels. Patient was not able to sit unsupported, using more of postural control strategies, sitting tolerance, preventing the contraction and muscle weakness should be the major goal. And working on more of orthosis, splinting, positioning, casting, and adaptive equipment such as bracing is something that is we got to really look into. Patient able to sit unsupported, most probably from the transition development point of view, we got to look with the transitions such as laying down to sitting, sitting to kneeling, kneeling to standing, standing and stepping. So these are all the transition that we got to work. And what are all the orthosis that is going to be supporting for this transition we got to look into. And patient who is able to ambulate, maintaining their highest level of function, maintaining the task of how to maintain the endurance, how to maintain the activities of daily living should be the thing. And thoracic and cervical bracing appropriate to the posture while sitting. And gait training devices something that we got to consider for different functional level of SMAs. And what could be the post-operative scoliosis? Post-operative scoliosis, initially after a surgery, first 0 to 6 weeks, it's all about maintaining the ROM, supervised ambulation, postural correction, and safe techniques such as transitions from bed to sitting. And from 6 weeks to 6 months, brisk walking, good amount of endurance and core strengthening and gait re-education should be the task. And from 6 months to 1 year, the target should be return to sport activity or function, guided good amount of strengthening activities, balance and agility, sport specific, and return to activities. We have all seen a good number of triads, how these therapy work. And with the previous presenter pulling out all the recent advances such as like CME, DMI, and NISTIM concepts into it. I'm a certified DMI practitioner as well as I am a certified NISTIM practitioner also. I've seen few improvements after child using DMI techniques for trunk control and DMI techniques to improve the transitions from laying down to sitting, kneeling, standing. And NISTIM definitely helps with a protocol of dampening and protocol of activation, which means dampening protocol is nothing but to maintain and to prevent the contracture by maintaining the muscle tone, as well as the activation is whichever the muscle group that is weak, we got to set the electrodes that way. So kind of safest form of non-invasive muscle stimulation. And this is one of my PhD proceedings, and this is the recent article that has been published, a case study that is done on neuromuscular diseases, especially with this SMA type 2, where the child was admitted with the age group of 5 years. at the Manipal hospitals. What I could take the point here is with the use of cough assist device, along with the traditional whatever the chest physiotherapy techniques we have used, we have seen that the transition of shifting out from the ICU to the ward, to the OPD, to the ward, to the home care is being easily transited, and thereby reducing the cost of the hospitalization, thereby reducing the respiratory risk and respiratory well-being also. So these are all my reference, and thank you for the team. I am nothing here without my team. So thank you, my team, for giving this opportunity, and thank you, ODI team, and all the delegates over here for spending your valuable time. Over to you for the further questions.
That was an excellent talk and wonderful video demonstrations of various methods and devices and all. It was really good.
Thank you, ma'am.
Next, I would like to call upon Dr. Vinita for the orthotics and assistive technology in the management of spinal muscular atrophy. We'll take all the questions regarding the respiratory management, physiotherapy management, and the functional outcome measures to the end. Please post your questions in the question and answer box or in the chat box so that we can discuss it out.
Thank you, Dr. Smilu. So this is actually a very interesting era that we're in terms of spinal muscular atrophy. More so because like how Mrs. Neha was talking about classification. So I think it's we're sort of moving away from the type 1, type 2, and referring to more so functional classifications. Simply because somebody whom we didn't expect to ever stand now with the disease modifying drugs are able to stand. And so I think that's the most interesting aspect of rehab that we're going through right now. So when we talk about non-sitters, I think one of the things that we had to do at least was sort of innovate. And one of the, as you sort of innovate, you also realize that you make mistakes along the way and you tend to learn from those mistakes. So what we used to do is, especially the non-sitters, we used to give them car seats and try to make them sit. If you notice this child, he was post gene therapy, but also as soon as we got him into the car seat, if you see the thoracic wall falling and compressing over the abdominal wall. So this is not something that he really tolerated for too long. And so even though, we gave them back support and his back was straight. So what we realized was that this child who has been lying down most of the time, suddenly when we put him upright, was not able to tolerate it. So over time, with therapy, actually the parents got him into an upright position. We were able to brace him with the cervicothoracic brace. Now, most of the time we're asked how often and how long. So for any sort of orthotic device to be effective, we at least need, what we would say a minimum 60 minutes to overnight. And for the brace to actually be effective, it has to be worn 5 times a week. So most of the time we are telling our parents is, in terms of resting splints, to typically wear it overnight. And this is something that if you get the parents on board, the children are more so compliant than not. So what happens in the non-sitters is because they're not used to sort of having been propped up. What happens is over time with the car seat, as much as there's a tilt in most of the car seats, it wouldn't give enough inclination and sort of progression that we desired. So the team of orthot is actually Miss Mahima and Emmanuel did a lot of work in progressively making the child upright. So this is something that we have gone through in terms of even having a child with the tracheostomy and the peg tube upright over time, and they've been quite successful this way. In non-sitters, again, you're trying to prevent as much contractures as possible. So this is the same child whom I had spoken about initially, his post-gene therapy. If you notice the hand deformities and the leg, so over time this was all corrected, and you saw him a year later at follow-up. In this is, still we're still going back to the 2018 guidelines when we are talking about um, a standard of care. So what's interesting is all the way in 2018, they talk about, lightweight rattles and bath equipment and adaptive beds and hoists. These are things that while we keep in mind, I find it harder to translate into a daily clinical practice. So even the eye tracking devices for computers and communications, it's easier said on paper than into practice. But this is something that with the support of a few families, we're actually able to do. So the sitters, I think one of the most basic principles to keep in mind is the type of orthosis. Now, to differentiate between an AFO, KFO, and a HKFO. So an AFO, ankle and foot. So like the name suggests, you're stabilizing the parts as described. So ankle, foot, orthosis, you're stabilizing the ankle and the foot. If you need knee stability, then you go for a KFO. And if you need to stabilize the hip, then you go for a HKFO. What's quite interesting these days is the various type of joints that are available. So what earlier, I think most of the sort of apprehension to prescribe the KFO was the weight of the device. We are able to get lighter weight plastics, lighter joints, and also the types of joints have evolved where we are able to use the muscle power of the child along with the device to actually just ensure that the child is able to do a movement, and the orthosis gives the stability to the child. So one of the joints actually that we really like now is an offset knee joint. So it lets the child with a good quadriceps power use the quadriceps power while also giving stabilization at the ankle and foot. So the turtle brace is something that I think maybe a handful of children here have. One of the advantages is that it can be done weekly if the child wants to remove the orthosis in terms of comfort. So the turtle brace, what it does is you can mold the brace. It's sort of like a serial casting. So you can mold the foot and progressively change the angle of the ankle. So this is something that is sort of just come in, and with expertise can actually be done quite easily at home. The standing frame. So supported standing, again, I think there are, like Mrs. Neha said, again, it's necessary to know when and how to make sure your proper alignment before you get a child onto the standing frame. I talk about hips slowly so that we can get back to that. Scoliosis, so far our guidelines for scoliosis is quite straightforward. Anybody above 15 degrees and less than 45 degrees. So that is what your bracing angles are. So if you see anybody within that range, okay, the TLSO is on. Less than that, one of the things that we have found useful is this sort of compression device. So it goes in, it's for two names. So you have either the Theratox or the Spio. What happens is it gives sort of a proprioceptive and counterbalance to the child. So thereby preventing this sort of kyphotic posture, and also because of the proprioception also the children tend to sit better. Now, does that translate to better spines over time? That's something that we don't have evidence for. The TLSO is quite, I think a lot of parents, especially those who have children who have PEG tubes, are a little apprehensive. But I think this is quite straightforward. As long as there's a cutout for the PEG tube, there's absolutely no restriction on it. What happens is the child has to progressively get used to it. So what we're aiming for is anytime the child is upright, the brace is on. That's what you should aim for over a couple of weeks, and most often again quite achievable. So this is the fun part of therapy. I think again, Mrs. Neha spoke about aquatic therapy, swimming, and things like that. But what's interesting here is all sitters having an electric or power wheelchairs with custom postural support and seating systems. This is something that we, unfortunately, as a country, we haven't achieved in the sense of having customized seating systems for every child. Most often, you will see, okay, wheelchair is prescribed, but most often those wheelchairs are going to cause secondary deformities unless they're actually customized for the child. So this is something that's important for us to keep in mind when we prescribe. This would be, of course, a dream to have lightweight manual wheelchairs and power assist wheels. So these will let the child or sort of be a little more independent. Now, along with the wheelchairs, you also need access in terms of the road and things like that to be able to use these wheelchairs. Yeah, so this is, I think, world over, not just in India, we don't have any sort of guidelines for the hip. And interestingly, this just came out last month, where they're talking it, and this is a Delphi consensus. So what happens is they've actually taken the sort of hip study from cerebral palsy and sort of translated that into SMA. Now, a lot of questions about tone and the way the muscle phenotype is different, how can it be applied? So the principle behind that is, despite the difference in the phenotypes, what happens is they notice similarities in the proximal femur, and these changes are interestingly irrespective of the tone of the muscle. So that's how they sort of we're sort of applying the CP hip to SMA hip. Now, so again, we are still a little undecided in terms of how to go about it. But one of the things that, again, I found quite useful is the hip screen as an app that is actually already available. They have the migration percentage ruler. Now, what we do know is that if there's more than a 30-degree sort of displacement or subluxation, rather accurate word, that is when that hip is at a higher risk for a displacement. So those are the hips that you have to be careful of. Now, everybody talks about prevention of subluxation, but really the principle behind it is typically strengthening an orthosis, where you're supporting the hip and trying to prevent a displacement. This is actually a lot easier said than actually done. So one of the things, again, we have, because of the lack of evidence behind actual proper management of it, what we have sort of as a team, if we see anything more than 30 degrees, we do a yearly hips X-ray. And so we're actually quite careful on screening for these hips. So if we see the hip sort of migrating more than 30, then we're careful. And then at 50 is when we sort of refer to ortho, mostly to see if the possibility of either the growth plane modulation surgery or the more advanced surgical techniques. So one of the things is in terms of complications, naturally, because it's a Delphi consensus and the lack of evidence, most people preferred the less complicated approach. So this is what we have thus far of the hips. Yeah, with that, I'm going to end my talk. So thank you, Dr. and Dr. Smilu, and Mrs. Neha and Gauri. And finally, none of this would actually be possible without Ms. Mahima, because they translate all of what our thoughts are, our ideas of biomechanics into actual devices. So they're the prosthetic and orthotic team that actually help do this. So thank you.
Thank you, Dr. Vinita. That was an excellent talk. And every time, even I used to wonder how they are wearing the TLSOs comfortably. And I really know the importance of the material, because when the TLSOs are usually prescribed, and if we don't use the right material, it can really get uncomfortable for the child. And though we know that the studies wise that it is not going to prevent, but maintaining the sitting balance and sitting posture is very important. And just I have a question, like how do you make these children sit in their school, like the type 2 SMAs who are actually school going, and some of them they don't want to sit in the wheelchair and they prefer to sit on the bench. So any specific measure that you advise for them to make them sit on a bench without much problem and discomfort?
So this is actually sort of a debate that we have every time, but especially somebody who's a sitter comes in, like, we don't want to use a wheelchair. One of the things that we have sort of managed is we create a modified chair. This is actually a wooden chair, resembles their benches. So some of them don't mind using the wooden chair. So they can place it like just next to the bench, so they can sit next to their friends. So that is something that we have actually managed. So during this time, we're making sure, okay, you're assuming the child has their brace on, right, under their uniform. So the brace is on. We make sure the feet are flat on the ground, supported. And so that itself is sort of an aid to help with alignment. So that's how we manage.
That's nice, actually. So that's good. That's a good idea. And any specific devices you help for them in case of toileting? Because that is another issue they face at school. So we have many schools where the toilet seats are not like proper for these children. They don't have Western toilet at times, where we have to write letter for them to have a Western toilet for these children. But at the same time, to make them sit on the Western toilet, do you have any such assistive devices or anything that can help them to move, transfer basically from one place to another?
So, so interestingly, just this Saturday, we had a child who, she had to use the washroom in school, but like you said, it's not a Western washroom. So, and weirdly, the teacher washroom isn't Western either. So sometimes we actually resort to doing that, in the sense of, we'll write out letters like you do. Can you use the teacher's washroom? But so this is another thing that we sort of adopted from another cohort, is actually the spinal cord injury cohort. So in sort of rural communities, what they'll do is they'll put a wooden sort of a bench over the Indian washroom.
Yeah. Okay.
Yeah. So that is something that, because it's portable, if the school will allow it, that way the problem of sitting, is sorted. And then unfortunately, because of the way the accessibility is, they would actually have to use a tap, or because installing a grab bar is something that would be ideal but won't happen. So then they resort to using the tap to sort of get that support to sit. So far, that's sort of what we came up with, at least for this child. Yeah.
Yeah, it does solve to some extent. Yeah, that's good. Okay. So any questions from the participants? There was one question. I think Ms. Neha has answered the question. It was on how the FITT principle is applied for cardiovascular exercise, where intensity can be quantified using measures like heart rate, volume O2, and METs. And it was regarding the submaximal strengthening. How do we objectively define or understand submaximal strengthening within the FITT framework? So can you just explain that, Sneha, so the other participants are also benefited?
Sure. So, first thing is, these are children we are talking about. So, many things other than just cardiorespiratory things can, interfere in a therapy session, like simple behavioral problems. You also have not slept better the previous night, on the way the travel was too long, and things like that. So this is a general pediatric therapy related problem. But how do you know that too much is how do you know the intensity of the session is too much? Please talk to the parents on how the child is doing post session, and how the child's schedule is going on the day the therapy happens and otherwise when the therapy is not happening. So that way you can compare and say, okay, this is the intensity where we are at, and at home, how much of time the parent is supposed to be practicing these exercises. So that's a very subjective way. And apart from that, I think talk test is something that you can use where you keep talking to the patients when they start to hyperventilate, the voice sort of reduced and the voice breaks out of exhaustion. So that's one way to understand that this is becoming too much, where the exhaustion is so much that they're unable to generate voice or talk continuously. So talk test is another way. And older children, yes, rate of perceived, just like how we ask a VAS scale for pain and things like that. So RP definitely is useful. So that's what I would say. Ma'am, you're on mute.
Sorry. There are a couple of questions. There was one question on what material are ideal to be used for orthosis for comfort, which does not cause friction or scar. So I think Dr. Vinita can take up this question.
Yeah, so most of the time, all of your plastics are what we're using. So there are various types of polypropylene that have actually come out, and the other thing is carbon fiber. We're actually starting to use carbon fiber a lot more than we were maybe even a year ago. It's really lightweight, and that is something that the kids really like. So carbon fiber, expensive, less modifiable in the sense the PP sheet is something like if the A4 doesn't fit, you can heat it, expand it a little bit, whereas the carbon fiber doesn't let you do that. So yeah, I'd say our go-to right now is carbon fiber and polypropylene. Again, thickness, depending on your orthotist, I'm sure that they'll handle the thickness to the minimum required in terms of stability, but also comfort. So that is something to keep in mind.
Okay. Thank you, Dr. Vinita. So I have a question to Gauri ma'am. So just in case we don't have time in a busy clinic, and if a physiotherapist is like occupied with a lot of cases that day, and if they have to do a quick screening of all these patients, so what would be the go-to scoring for type 1, type 2, and type 3, where we can do it quickly to know whether they have improved or not improved, something like a quick measures. So among all the things, like for example, in type 1, you measured a lot of functional scales. So what would be the best one among everything so that we can do it quickly at the same time it's more reliable?
Okay, so for SMA 1 and 2, if the if the child is very, very weak, it depends on the functional status. That's number one. So if it is a weaker child, we have to start with high knee and chop. So chop intent is something, if you are if the therapist is well trained, you can do it in 15-20 minutes also. But as you said that, okay, busy OPD and everything. So basically, if the selection of the functional outcome measure is correct, then it can be done. So for seaters, you can go with HFMSE and RULM. So what I mentioned was actually, I mean, that is the way you go ahead. The only thing is here, I feel the training of the physiotherapist and to see what exactly has to be seen in a quicker way. Like for example, if the child is ambulant, but we have to see their HFMSE and MFM, what I mentioned in the slide. So what we do is when the child is lying down, we know because we have been doing it for many years now. So what we do is all the items from all the tests we see in lying position. Then we make the child to sit. Then in sitting, whatever are the positions like maybe the RULM also, that is in sitting, the upper limb function. So we finish that. Then we go on standing and then we go on walking. So this is a quick way. So first you go to the posture and like what is the maximum functional status of the child. If the child is standing and walking, again you will have to do all the things. But if the child is not even rolling, obviously the high knee and chop will give you the exact score. Then you don't have to see how either the child is sitting and how the child is rolling, because many therapists do that mistake. But we don't encourage, because if the child is not even sitting, there are items to check in HFMSC in rolling also, but the main thing is the sitting. So HFMSC starts with sitting posture. So if that is not there, then you don't have to go for other tests. So it's nothing like what is the best. It's not like that. All the tests are giving you the best scores only. But only thing is the little bit of training and little bit of clinical reasoning also, because few things are common in one test and the other test is also like say similar items. So once I mark in one test, immediately I will go to the MFM and mark all those tests, all those items, so that I'm not tiring out the child. Because if I go in sitting, then I make the child in standing, then again I forgot one item, so again I'm making the child to sit. So in that transitions also they get tired. So knowing about the scale, what are the items to be checked, if that understanding is there in the therapist, then you can do it quickly also. That is our experience.
That's right.
Dr. Ann wants to say something.
Yeah.
Sorry, Dr. Smilu. Just one thing I wanted to say. One of the things with Dr. Vinita, you had asked that great question about the seating. I think what we do is we persist. So the junior sees him, Dr. Himshita, somebody fellow sees him, and she would have already warned them that I'm going to see this, and I'm going to say that they need to take seating to school. So we do that. And then after saying that, I'll say, what would happen if you don't do that? Then we are doing the exercise of sending them to another person who's going to say only that. So just because 3 or 4 of us are saying the same thing again and again, they tend to comply a little bit more. I'm not saying everybody complies, but I'm just saying that every year the compliance is getting better. Or maybe we are getting better at bullying people. I don't know. I don't know what the answer is, but it seems to be less effortful. And with regards to what she was saying, many times when you're doing the physio assessments, because sometimes we are stuck with parents asking us question, so should you stop risdiplam or should I do this? We are very much reliant on the scores. And children are children. They will not cooperate for something. They might not necessarily have a bad worsening upper limb function or a lower limb function. So we need 2, 3 scores to be able to correlate. So if they end up doing half and half, so often we end up pulling our hair and we don't know what we're doing. So we've done the scores for just for the sake of doing the scores. And one of the things I've noticed as well, because I work with many physiotherapists, and now there's the 3 or 4 of them whom I work frequently with, and more so with Gauri and Sneha. Initially, it used to take 1 hour and all that, but now they do fatafat just like that. And I'm the one who's lagging behind. They have finished their job. I am not finishing. So I think it's just practice and ease. It's very doable. It looks daunting. The number of sheets look daunting, but they've gotten very used to doing it.
I think to add to that, I think if it's a pediatric physiotherapist, things get more easily done.
To a certain extent, but there have been instances. I remember there was an adult physiotherapist. Rahul was there, no? Who's adult? He was so much better than our pediatric physio, because the child threw a tantrum, they would just get scared, and they just got their assessment longer. Whereas Rahul was, what is there? You don't need to do it that way. Play with the child. Do this. You saw this moment, that moment, and randomly notice it. Just like what you would do with a neurological examination. You're not going to go from CNS, cerebellum, cranial nerves down to other things. You're just going to opportunistically do it.
So I just wanted to tell one last thing, Dr. Smilu. I think we spoke about a lot of new therapies right now, that DMI and everything else. I'm not here to say they don't work. I'm just saying there's no enough evidence for us to put our foot down and say this is going to work. So whoever is practicing NISTIM and other therapies, I'm asking you to just be cautious about it, because fatigue is a very important factor to consider before going a little intensive about things. So, and regular contracture check and assistive devices absolutely necessary. That's the blanketed opinion right now. Right.
Okay. Ma'am, do we have time for one more question?
We have as much.
Hello?
Sorry, our time is over. People are still there. Up to you.
Yeah, just one last question I
Okay.
can do. So, what could be an ideal age group of children for ACBT techniques and PEP devices?
The question, I guess I should be able to answer better.
Yeah, you are the one who
Yeah,
is going
yes,
to
yes,
answer
yes.
this.
Yeah. So most of these techniques needs a lot of comprehension. Most of this technique needs a lot of instructions to be followed. So in that way, if you ask ACBT or any other techniques would be definitely above 6 years or above 8 years in some children. And most of the children with SMA type 3, the cognition is good, so they'll be able to do by at end of the 5 years also. And before attempting any techniques with oscillatory PEP devices or any technique that is related to the such as acapella, aerobica, flutter, and all those things, I would just say, based on my clinical opinion and clinical expertise, I just give them basic blowing because most of the children's expiratory flow bias is actually less. We may say that we can easily make the child to blow over such a big equipment, but for them, blowing a paper could be sometimes difficult. In the same triad of SMA3 or SMA4, we think that the respiratory muscle strength is quite good. But if we ask them to blow at the different level of like 10 centimeter or 15 centimeter, that could be a part of an integral assessment. If they are able to do that, tick and then go for the next equipment. Ideally, anywhere between 5 to 8 years is somewhere we take a call whether to give or not. The agenda here is a good amount of expiratory flow bias followed by testing the equipment based on the least amount of vibration resonance. Acapella has the least amount of vibratory resonance. It's just a kind of a blower. So we can easily give. If you ask flutter or if you ask aerobica, it needs enough amount of respiratory strength or the expiratory strength for them to blow out. So in that way, I would suggest that wait for the span of 5 to 8 years. That is the ideal way. And there are other set of exercises are also there. We should not just not consider the other expiratory flow bias exercise. Even in terms of a basic functional cough stimulation followed by one or two huffing and coughing would be able to act as a better airway clearance modality also. So that's the reason of me putting at a point of basic techniques, breathing control techniques, and the instrumental techniques, followed by what if in case of if all these things are not applicable for a patient lying down on the emergency ICU, comatized, low GCS level, having a neurological sequel, following a respiratory impairment, the patient has a low GCS, they cannot participate in any of these activities. Only the thing what we could do is only PDPV, postural drainage, percussion, and vibration. That is why I had highlighted the point of cough assist because cough assist doesn't need any of the patient participation. It's just a modality that sends a passive pressure to varying different lung lobes with the different pressure we set, and it sucks out and takes out the secretion to take out the more amount of airway clearance what we see with the children who's cooperating and comprehending than using cough assist. The actual way of airway clearance is much, much better. So as a practicing therapist, as a beginner in the field, as a novel in the practice, the take home message here is we got to decide first understand the child's mentality because how do you see we are not going to see the child in a playful environment. Obviously inside the hospital environment the child is very apprehensive. Everybody who's coming to see the child will be in their mentality that they're going to prick me, they're going to put some injection or something like that. So we got to first understand the child comprehension and mentality. Usually children lesser than 5 years, I would prefer that choosing a cough assist would be the best advice even if they are cooperative. It is easy to take out the secretions. Or if the child is very well participating in a good amount of expiratory blowing or expiratory strength, if you feel personally, then what I could do is start with a cappella. And if the child is having good amount of expiratory with the a cappella, I would prefer doing aerobica in that way. But the biggest disadvantage over here is what about sterilization and sanitization? Because it's all cost effective. We got to convince parents that we got to decide a wise call that choose one equipment wisely. So I have always given an option of you choose Arabica, it's costly, but it will serve you the purpose. Or if you're not that much of affordable, what I would say is go with Arabica, a cappella, or flutter that is in the least amount of the price. So that as a parent, if you give them two, three suggestions, they will be able to make out a better so that the treatment plan goes smoothly. Because the treatment is not going to end up at the hospital or the OPD itself. Most of the respiratory therapy actually helps us when they do better in the house environment. So these are all the comprehensive thing what I could put for the question asked by the participant.
Thank you. Thank you. That
Thank you,
was
ma'am.
good and elaborate. Thank you.
Thank you. Thank you.
I think we can close the session if there are no more questions. And I would really like to thank all the speakers who did really well and could clarify a lot of things in the management of SMA. Dr. Ann, ma'am, any questions?
Just a vote of thanks. Thank you very much to Dr. Smilu for agreeing to do this. I know that you have lots of things other than OPD and at home. So thank you. And thank you to all the speakers. Thank you, Mr. Mohandas. And same with Dr. Vinita.
Yeah.
She's managing a lot on her plate. Thank you, Dr. Vinita, for doing this, and all four of you for rehearsing and getting this sorted. So thank you, Ms. Gauri and Ms. Neha. Thank you so much. And thank you, ORDI and Ms. Chetana. Chetana for being there till the end. Thank you, everybody. Thanks.
Thank you.